So, in Greece, most of the elbow replacements we do either for fractures or for fracture sequela. There are a few rheumatoid patients, but very few comparing to the UK and Northern Europe. The types of total elbow replacements, there are the linked, unlinked, and the convertible. In the linked total elbow arthroplasty, that means the two components are connected, and there have been quite a few types during the years of linked arthroplasties. And for the linked total elbow replacement, the bone stock is not as essential as for the unlinked ones in order to place one. The capsular ligamentous stability is not as essential, although new data suggests different. And you can do more extensive release with the linked prosthesis than an unlinked without worrying about complications. And there are quite a few risks with the linked prosthesis. Traditionally, the problems with the bushing of the Mori prosthesis, and there are more stresses on the linkage of the implants, and also there are more stress on the bone cement interface, which were relating with loosening. Of course, there are more new designs, and theoretically they give us more. They're supposed to be better, but that has to be proven. And with the linked prosthesis, that will allow us to put to use it for. This is a case of a lady who had elbow dislocations. She's been operated several times, developed a very unstable flail elbow, and the only solution for her was a linked prosthesis, and this was a discovery prosthesis. And that's a few days after the operation. She's already started moving her arm around. The unlinked total elbow arthroplasty, again, we had several types of prosthesis, and the two components, they rely mostly on the soft tissues, on the bone that remains, and also on the alignments. The stability relies on the alignment. I remember when I went to Liverpool, we used to take off quite a lot of this. The Camid is one of the first elbow replacements. At least they were easy to remove. And then we had the Kudo and the IBPs, which we used for either rheumatoid patients or fractures as well, even with unlinked arthroplasty. For the unlinked, we have to have a decent bone stock, and you have to rely on the capsular ligamentous stability, although quite often you have to do releases, especially in rheumatoid patients, in order to balance it correctly. And you require collateral ligaments and dynamic soft tissue forces for stability. It's more technically demanding than an linked prosthesis, placing an unlinked prosthesis. That's what I think, anyway. The problems with the unlinked, there were the instability, the dislocation. Also, there was quite often polyethylene failure, and that's because of maltracking of the prosthesis. And also, sometimes we had also loosening on the tip of the olecranon. Recently, it's been developed the convertible total elbow replacement, which allows you to select either a linked, unlinked, with or without radial head replacement, depending on your experience and your indication. It's supposed to be for easier the revision from an unlinked to a linked. And also we heard about the hemi-arthroplasty. So there was, again, the question, which is the best? Well, both of types of elbows, they have good clinical results, of course, in the appropriate hands of surgeons who specialize on that. A review from New Zealand showed that the Conrad Mori had 65% lower risk for revision compared to Latitude, either linked or unlinked. And also another paper from Graham King shows that they had about 23% problems with the radial head implant, using it as a part of a total elbow replacement, either for dislocation, dissociation, or subluxation. So there are problems there as well. And in the question, should we use Link for a specific group of patients or not? Paper showed that in younger patients, in rheumatoid patients less than 50 years old, the unlinked have equivalent good results with the linked prosthesis. And there is some discussion in another paper whether we should use unlinked for younger patients, because in the unlinked prosthesis you have the problem that it might dislocate, then you might have to revise it to a linked. In the linked prosthesis, because you have increased stressing, you have a problem with, you may need to revise it because of stem loosening. However, both of them, they have the same more or less rate of revision. So the choice design depends on of course, the bone stock, the soft tissues, and there is a cadaveric study that showed that maintaining good soft tissue balancing and reconstructing the ligaments, it's better for link prosthesis as well, but that was a cadaveric study. Of course, it depends on the patient profile and the experience of the surgeon. Thank you very much.